Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, my name is Darlene Davis. I'm a partner in the firm's Research Triangle Park office, and I'm joined by my colleagues, Andy Ruskin from our DC office and Lauren Norris Donahue from our Chicago office. Andy and I are part of the firm's healthcare and FDA practice, and Lauren is part of the firm's antitrust, competition, and trade regulation group, and she does a lot of work with healthcare clients. So today, in this episode of Triage, we're going to be talking about data that's available in light of the hospital price transparency rule. Andy was mentioning that Turquoise Health recently published a report showing that 85% of hospitals have posted negotiated rates in response to the rule, along with 80 insurance carriers that have reported rates covering a majority of covered lives in the U.S. So to get us started, Andy, do you want to give us a quick overview of the hospital price transparency rule and what it requires?
Yeah, and Darlene, let me underscore the point you just made, which is how incredible it is that we're up to 65%. Some might be thinking, is it less than 100? People have to remember that all of a year ago, there was a report in JAMA that said that there was only 6% compliance. So we're now in a really different environment. So just to refresh everyone's memory, the price transparency rule has been in effect since January 1 of 2021. It followed the loss by the American Hospital Association in federal court. It stems from all of about 5 words in the Affordable Care Act, which turned into roughly 97 pages of 3-column, 8-point print in the Federal Register during the Trump administration. This has always been wildly unpopular, which would explain why this was 6% compliance initially. And the reason it's so unpopular is because it's extremely burdensome and is viewed as relaying information in the public domain that's really no one's business and doesn't really serve any legitimate purpose from a healthcare regulatory perspective. The major components of it are twofold. One part of it is that there is supposed to be a disclosure of shoppable service pricing, which by itself is not entirely terrible. It's a requirement that you choose approximately 300 services that you know are the types of services that patients are likely to be shopping around for, and you can either provide certain price data points pertaining to those services, or you can put a tool on your website that allows patients to enter in certain information that then results in their being able to get an estimate as to what their costs will be if they come to your institution. The second requirement, however, is where there's been all of the controversy, and that is that you have to create a machine-readable file that doesn't just require you're putting up your charge description master, aka CDM charges, but also requires that you put all of this data regarding every item and service that you make available either to insurers or to uninsured individuals at whatever price point you make it available to them. So this is, a file that's in a JSON format or comma delineated format. It runs for hundreds and hundreds of thousands of lines. It's prone to error, of course, and is outdated the second it's loaded. And there's clearly no need for this file for any patient. This is merely for researchers and potentially for competitors. And so this is why it has really been a question mark as to why the former administration thought that this was appropriate. But that being said, we did go from 6% about a year ago to 65% now. So hospitals have relented and are now starting to comply.
So Andy, curious for your thoughts as to why, given, if only 6% of hospitals were complying last year, why do we think the rates have increased so dramatically to 65%?
Yeah, that's a great question, Darlene. You certainly wouldn't view hospitals as coming into compliance without some sort of external incentive, and they do have one in the form of that the current administration last year in the final outpatient rule increased the penalties from essentially a maximum of $100,000 to, depending upon your bed complement. If you've got a bed complement of 550 beds or more, the penalties can now be more than $2 million a year. So hospitals have had a choice. They could either tempt the agency to truly impose enforcement measures, or they could just come into compliance. And so many more have, but not all have. And I will tell you that as a lawyer who prides himself on his knowledge of the Administrative Procedure Act, I can tell you that I have some serious reservations regarding CMS's authority to impose these new penalties. The AHA lost, but not on the penalty provision. They lost on some other unrelated provisions altogether. And so maybe the 35% that are not complying are planning to challenge CMS in court. And it's quite possible that one of them will win because the agency really does not have that authority. But that being said, 65% have, and it's quite possible, therefore, that for them, they may even have found a benefit here. So anything's possible.
Understanding, obviously, like you were just saying, right, the potential enforcement actions and civil monetary penalties that can be imposed for failing to comply, what might be some upsides of this data being publicly available?
So my perspective is it's great to have all of your competitors' data and, as you said, insurer data regarding pricing, because now you can data mine to your heart's content, and you can basically set your prices at the optimal level to achieve your competitive goals.
And it certainly sounds like some of those files are not necessarily conducive to consumers' ability to determine their rates, given the format they're in and their length.
Yeah, no, there's no doubt, but it's certainly something that hospitals and health systems can figure out how to finesse and data crunch, and so that's where probably the real use of this information is going to come about.
So once we start talking about the use of this data for competitive purposes, Lauren, wanted to get your thoughts on kind of what hospitals might be able to do with this data.
Sure. So, the antitrust laws don't prohibit an independent entity from using publicly available information to set their prices. There's nothing wrong with that. They can use publicly available information. The big issue in the antitrust law is obviously you need to make your own independent decisions. You can't coordinate or reach agreement with your competitors about those pricing decisions.
So does that mean, though, you can put all of your prices on an array, all of your competitors' prices on an array, and you can figure out which one is in the middle point of each and every item you offer? And can you then also use that information in negotiations with payers? Can you say to United Health, I'm not charging you $85 any longer for 10 minutes of anesthesia. I'm charging you $95 because you're paying St. Vincent's around the corner $95.
You can. I mean, under the antitrust laws, you can make your own independent decision and go into the negotiations like that. That's not to say that that's not without some antitrust risk. So, like I said, the risk of the violation of the antitrust laws is an agreement or understanding with your competitors to fix prices or to coordinate on prices. And so while you can make your own independent decision using that data, you need to be very careful that you are not raising any suspicions or coordinating in any way with your competitors. So if it's your own independent decision, there haven't been any communications with your competitors about that data, there's nothing that's illegal about that under the antitrust laws. But you do, I think, incur some increased potential scrutiny if you are using those as negotiation leverage or talking points in your negotiations. So you just need to be careful that you're not increasing your risk.
How so, Lauren? What would be a problem in terms of leveraging that information versus what would be a safe way to approach using that information? Again, let's say it's $85 versus $95 for 10 minutes of anesthesia.
Good question. I think where it's less problematic is that if you're in a negotiation and you are pointing to the data that has publicly been disclosed by St. Vincent about the charge that they're charging, and that the payer's data reflects that same price. And you can have that negotiation with the payer and saying, look, like we see this in your public data and we're going to only accept $95 for that service. I think where it becomes much more problematic is if you are in any way coordinating with St. Vincent, your competitor, about what that price is going to be. If you make statements to the payers about the fact that you expect that St. Vincent is going to do something, or you and St. Vincent have agreed that you're only going to accept $95, that's where you get into extremely risky behavior. So you just want to make sure that you are really making your own independent decisions, that you are basing any of your negotiations with the payers on publicly available data and not on any communications or knowledge about what competitors are going to do. And you want to make sure that you have trained your people that they should not be talking about any of that publicly available data with their competitors, not talking about what they expect future pricing to be or what their negotiation positions are with the payers, and even avoiding discussions with competitors about how they're using the publicly available information in their negotiations with payers. That's all really off limits and extremely high risk behavior.
So what about something that you only have to update according to CMS rules? You only have to update your pricing file once a year, which, again, for commercial reasons, it doesn't, because your prices get updated much more often than that. But what about if you and your competitors all start a habit of updating your prices every 2 months, and you all do it exactly on the first day of the month? Could you see that being a problem? You're not having a conversation with anybody, but everyone's prices are available every 2 months on the first day of that second month. What's your assessment of that as an approach for trying to harmonize pricing?
I see that as pretty risky and kind of incurring additional likely scrutiny from the agencies. One of the things to keep in mind with antitrust law, as I've said, is that, it's an agreement or understanding between competitors that is the violation of the antitrust laws. But an agreement or understanding does not need to be in writing. It does not even need to be orally said. It could be a gentleman's agreement, and it can be proved by circumstantial evidence, such as what we call signaling is one way to prove an agreement existed. So if there is the type of conduct where you've got competitors who are routinely updating their disclosures kind of around the same time at increased frequency that is not really necessary, or that there's not a legitimate business reason for doing it, all of that can be pointed to show that there was an agreement or a meeting of the minds, an understanding between the competitors, even though those competitors didn't have a explicit agreement to coordinate prices.
Lauren, it seems like there can be potentially a lot of complexity and, like you said, facts and circumstances to how the data can be used. Would you suggest that there be some parameters or policy in place if hospital clients want to use the hospital price transparency data files?
Yeah, I think it's always a good idea to have some policies and guidelines in place for the folks. This is, highly sensitive data that is going, when found in files, it can raise scrutiny. And so I think it is important to have a policy in place. I think that policy would, one of the main principles in that policy would be that the data can only be used for, independent business decision making, that the entity needs to come up with its own independent decisions, needs to decide what to do that's in its own best interests, and that it needs to be very well documented where that information is coming from, that it came from publicly available sources, that it didn't come directly from from the competitor by other means, and that there need to be clear guidelines and training in place for the folks who are accessing that data, that they are not to discuss or have any communications with their competitors about that data as well.
Thanks. It does sound like that is a wise course when wanting to use the data that's publicly available from an antitrust perspective. Andy, what else do folks need to be thinking about from a healthcare regulatory perspective in terms of making use of this publicly available data?
So, for years, we've always been concerned about hospital charges and hospitals having crazy charges, and there had been all of this, remember the whole reason that any of this exists is because for decades we've been talking about price gouging by hospitals and how hospital charge description masters they don't reflect actual pricing. And there's almost been a hysteria about it, quite frankly. But as a result, though, we have a number of other laws on the books. For instance, there's the OIG authority to exclude hospitals if they're charging Medicare or Medicaid substantially in excess of their usual charges. And OIG has several times tried to publish rules and has always found this to be too complex, and they've retracted their rules each and every time. That with all of the data available to them now, they may very well find some way to do something that actually sticks, and they'll have all the data they need without having to subpoena, and they'll be able to target hospitals that they're really concerned about. So, to the extent that charges are to Medicare are higher than all these other data points that you're furnishing to the public at large, then there may be some concerns there. Some states have most favored nations provisions for their Medicaid programs, and there as well, you've now offered your enforcement authority all the information they need to be able to go after you. And as well as in some cases, some of your payer agreements may very well have MFN clauses. So there are all of these other concerns that you should be focused on. Plus, there are these more nuanced concerns, such as if you're a transplant center and you're paid on a cost to charge ratio, whether or not your charges reflect anything real, because they're going to look at all your data points and they're going to say, wow, how are you charging, how does your charge description master say $5,000 for 10 minutes in the observation room when in fact you are charging no pay or more than $500. So now suddenly there could be grounds for challenging some of your reimbursement. So it just makes sense to make sure that as you think about updating your charges, you're being rational about how you go about doing that.
Thanks. I think those are a lot of good things to be thinking about on the healthcare regulatory side, in addition to the antitrust considerations that Lauren has raised today, as folks are thinking about opportunities to make use of the hospital price transparency data and not just thinking of it as an administrative and regulatory burden that they incur when they have to post it and update it. So thanks, everyone, for listening to this episode of Triage. And if you've got any questions about the materials that we've covered today, please feel free to reach out to your K&L Gates attorney.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.